Aibovan. And a very good evening to all our viewers here on TV1. And a warm welcome to all our viewers joining across the globe via YouTube as well. Usually we talk about a common disease condition that affects our general public. But today we are going to be talking about how you should prepare for a major surgery. Because we see major surgeries taking place day in and day out, but in our day-to-day medical practice we see that most patients who come in for these surgeries are not very well versed in what they should have done and how they should have prepared before coming in for surgery. So I think it will be beneficial for all our viewers across the board to go through this discussion, and you never know, you may have to face a major surgery or one of your loved ones in your family. So to discuss about this, we have invited Dr. Dakshitha Wickramasinghe. He is a consultant surgeon attached to the University Surgical Unit at the National Hospital of Sri Lanka. So a very good evening to you, sir, and thank you very much for joining us here at Healthline.
Thanks for inviting me.
So to get down to the topic, sir, now we are going to be talking about how one should prepare for surgery. So when a patient comes to you and you decide, okay, this patient needs surgery, then and there what are the things that you decide and you communicate to the patient, and what should the patient know when they go home?
So the discussion about having surgery and going ahead with surgery, actually it starts one step before. It is about the decision to undergo surgery. The first thing I talk or tell somebody when we've decided that they need surgery is why they need surgery. With the recent advances in medicine, there are many conditions which historically were treated with surgery which now do not need surgery. So the first thing we talk about is why that they are going ahead with surgery, and is there no alternative to surgery. It might sound strange that a surgeon is talking about non-surgical treatment, but what you have to understand is any treatment, and surgery is no different, will have complications, and if we can achieve the same result with a less invasive, meaning something that does not require cutting or something that does not require anesthesia, the chances of a complication happening is significantly lower than surgery. So whenever possible, if there is an alternative, we will go ahead with that option. Sometimes patients do not understand this, why we are not offering them surgery. So having made that decision to go ahead with surgery, we talk about few things. First is, what is the surgery, the actual surgery that they will undergo? What does that surgery entail? Are we removing something like, say, an enlarged thyroid? Are we recreating something that is damaged or diseased, etc.? And the next thing we will talk about would be the type of anesthesia they would need. Certain surgeries require a certain type of anesthesia and there is no alternative. So then our hands are tied, we have to go ahead with that. But a lot of many surgeries can be performed equally well under different types of anesthesia. So I always talk to my patient about their preferences to see what they would like to do, the anesthesia they would like to undergo. The next is the timing. When we talk about timing, as far as surgery is concerned, there are three broad groups of timing. One is called an emergency surgery. Basically, the patient needs to go into theatre at that moment. We cannot schedule that. The second category is urgent surgery, where we have to go ahead with surgery within the next 24 hours. An example would be a patient with appendicitis. The third group is an elective surgery, meaning it can be scheduled. So a lot of our patients fall into this group. For example, if you have a hernia, we can plan your surgery to a time that is convenient to you and that is conducive to the system. So that is the third thing that we would discuss, because we have to schedule that surgery. And of course, then comes the preparation for your surgery, and this would depend on a number of things. It would depend on the actual surgery that you are undergoing. So the preparation for the surgery for different surgeries would be different to one another, and the type of anesthesia that we are planning to follow. And then it also depends on any other medical conditions you might be having, because we need to make sure that your conditions are well controlled and is conducive for you undergoing surgery. So that's the basic discussion I would have with any patient that I plan on operating.
Right. So, depending on the urgency and the pre-existing medical conditions and the type of surgery that you are undergoing, so all these would be discussed with your surgeon, and the decision would be taken together with you rather than the surgeon making the decision by himself. Of course, if it's indicated, he would definitely explain to you why this is indicated in such a way, and all those would be an ongoing discussion with the surgeon. Now, we spoke about general anesthesia versus spinal, and this is a common question that most of our patients ask: can I undergo spinal instead of general, or can I be fully anesthetized as opposed to having spinal? So, there are preferences. So, if you can just explain what the pros and cons are, and in certain cases we know, of course, there is no alternative, we have to go for general or we can do in spinal. So, if you can just elaborate what is general anesthesia, what is spinal, and what does it really entail?
Okay. So, broadly, like Dilshan said, we have two types of anesthesia, well, two broad types that we commonly use. General anesthesia in essence is where you are unconscious for the entire duration of the surgery. So, that involves several things. A, you are unconscious, meaning you are asleep, so you do not know what is happening at that time and you have no recall of what has happened, and also during that anesthetic time your muscles are not working, and that is a part of the drugs we use to achieve general anesthesia, and the advantages and the disadvantages I will talk about are related to this. In contrast, a spinal anesthesia, where an injection is given to your spine to make a part of it paralyzed and not working. During spinal anesthesia, you are completely awake, you know what is happening during surgery and you will remember everything after the surgery. Some people do not like that idea of being awake during surgery. You do not feel any pain, you do not feel anything happening, but you are aware of your surroundings, you will hear what is happening inside the theatre, and some people do not like that. And that is probably the biggest reason that people want general anesthesia for their surgery. Now, the advantages and disadvantages of each are because of the mechanism or the way they work. Because you are unconscious or asleep during general anesthesia and your muscles are not working, there are certain risks. Now, when you are awake, although there is food in your tummy, it does not come up and go into your lungs because there are muscles that will make sure it does not happen. When you are asleep, and in this case when there are certain medicine given to relax your muscles, those muscles will not work properly, and there is always a risk that whatever that is inside your tummy will come up and go to your lungs. And we will talk more about this when we talk about fasting.
Yes.
But that is one of the main risks of general anesthesia. In spinal anesthesia, because those muscles are not paralyzed, that risk is a lot less. On the other hand, when you are getting a spinal anesthesia, there are certain changes that happen in the area of your body that is numb or anesthetized. So, there are changes in your blood vessels, in your nerves, etc. So, those may not be suitable for certain patients, like patients who have problems in their heart, because their heart cannot handle the changes that happen in these blood vessels. So, that is the situation where we would prefer to have general anesthesia over spinal anesthesia. That is a summary of the difference, but we can talk about more differences as we go on.
Yes. And now, when a surgery is decided, and depending on the each individual and the pre-existing conditions, we advocate certain number of pre-operative investigations, as we say. But again, on a numerous number of occasions I have faced, and most of our colleagues face, the patient, if they advocated, let's say, a full blood count and a renal function test and a chest x-ray, echocardiogram, whatever, so on and so forth, sometimes they say, okay doctor, I have this full blood count that I did 3 months ago, and they bring it along rather than getting a new one. So such occurrences have happened. So if you can just elaborate on what's the importance of getting these pre-op investigations, and what are we really looking at in those?
Right. So the investigations we request when you come for surgery may be due to a number of reasons. A, it may be related to the surgery that you are going to undergo. B, it may be related to the type of anesthesia you are undergoing. And C, it may be related to any other medical conditions that you may be having. Sometimes one investigation, say like a full blood count we have spoken about, will give answers related to all these. It is very important that you follow the instructions your doctor gives in getting these investigations. Now, for example, a full blood count will tell us a lot of things. If you are undergoing surgery, there is a risk of bleeding, and a full blood count will, for example, tell you your level of hemoglobin. Are you anemic? If you are already anemic, your risk is higher during surgery if you have bleeding. So, we would like to know what is your current level, and it also is an indicator to us how well you are fit or how fit you are to undergo surgery and anesthesia. It also tells us the status of your blood. Is it good enough to clot? Because if the blood does not clot, you will continue to bleed. And there are several tests like that that we would request. For example, if you are having major surgery, we would want you to undergo an echocardiogram, what is called an echo. And that tells us how well your heart is working. And especially under general anesthesia, but also under spinal anesthesia, when you are anesthetized, your heart sometimes is working under stress than when you are awake. So, we need to make sure that your heart is at its optimal condition, and we have an idea of what that condition is. And this goes on for a lot of tests. We would want to know, depending on the situation, how well your kidneys are and how they are functioning, how your lungs are working, and certainly related to the specific disease conditions also, you will be we would want to for you to undergo certain tests for us to know what your current status is. So, it is very important that you perform these tests on the advice of your doctor, because all the tests will not give us the information that we are looking for, and even more than that, you are putting yourself at a risk, because we are going to do a surgery in a situation where we do not know what your current status is.
Exactly. Your body is a dynamic machine, and a blood test or an investigation that you take at one point may not hold true as you go along. So, always follow the instructions of the doctor or surgeon who is treating you and who has planned your surgery, because they would decide based on your current situation that these investigations are required. Now, we spoke about the full blood count and the clotability of blood. We know certain patients are on blood thinners. For an example, the common ones are aspirin, then there is a drug called clopidogrel. So, a patient who is on these blood thinners coming in for surgery, should they stop these, and if so, how many days prior to surgery?
Right. The biggest factor in deciding what to do with this group of medicine is the reason why they were originally started. So, these blood thinners, what are called blood thinners, but they actually reduce the clotting of blood, may be given for a number of reasons. Some may be to prevent you from having a stroke. Some may be to keep the stent that was put into your heart working. It is very dangerous to stop these without proper medical advice, because you were started on that because the benefits of starting that medication outweigh the risks of that medicine, because all these medicine have the risk of increasing bleeding. So, the first thing I want to emphasize is that you should not be stopping those medicine unless you have been specifically advised to do so. We obviously need to stop certain medication, but we will balance that, balance the risk of stopping it versus the risk of bleeding if you were continuing this while you were having your surgery. A general recommendation is aspirin we do not generally stop. So, you can continue it until your surgery, that is for most general surgery. Certain situations like surgery in your eye or neurosurgery or surgery in your brain might advise you to stop aspirin as well. Clopidogrel is a medicine that is more powerful than aspirin. So, we generally advise you to stop it for maybe 5 to 7 days before surgery, and there are different other groups of drugs that reduce the clotting of blood like warfarin and newer treatment like apixaban. These again, the time to stop would be advised to you by your surgeon and your anesthetist when we discuss the date for surgery. Again, I want to emphasize it again, please do not stop these medicine unless your doctor tells you to do.
Exactly. One thing that we always emphasize here on Healthline is always follow the specific instructions given to you by the doctor that is treating you. Now, which brings me to the question, say if they were asked to stop it post surgery, when should they start it again?
Right. So, that is a very interesting question. So, we stop this medicine because the risk of bleeding during surgery, because these medicine work for a long time, and that is why we tell you to stop it for 5 days. Just because you stop it today does not mean the action of that medicine will stop by tomorrow. So, we have certain medicine that actually work that way, where we stop it now, the action will be gone in a few hours. So, sometimes if your risk of say getting a stroke is very high, if you stop this medicine, we actually start you on that second medicine. We might need to stop you, we might need to get you down to the hospital, but we start you and we change you into that medicine and stop your current treatment. And it is the same after your surgery. Once we are sure that the bleeding inside your body has settled or there is no ongoing bleeding, we will restart your medicine, and before your discharge we will definitely tell you what to do with your medicine. But sometimes before surgery and even immediately after your surgery, we may start you on a different treatment which does the same thing, but works for a shorter duration.
Exactly. So, that is one question that I as a medical officer treating surgical patients get on a day in and day out basis, because they are very anxious. Okay, I had my surgery, I need to get back to my regular medication. Some patients even take this medication on their own accord, not knowing that we had started something alternative to minimize and mitigate the risk. So, always in conversation with your treating doctor, decide on what medication that you should be taking. Do not decide on your own accord. So, that is the point that we want to emphasize. Now, talking about surgery, sir, we see so many diabetics who come in for surgery, and with the fasting, some may be on insulin, some may be on oral drugs. So, there are certain confusions among them whether I should take my regular medication on the day of the surgery, is it okay? Some overdo it and take an additional dose thinking okay, it will have an additional benefit by dropping my sugar further. So, what is your recommendation on that?
The management of diabetic medicine before surgery depends actually on the length of fasting you are having or the fasting you are doing. If you are not fasting, for example, you are undergoing surgery under local anesthesia where you do not require any fasting, we do not need to change your diabetic medicine. The reason for stopping most diabetic medicine or advising you to stop is that if you do not eat, but if you take your diabetic medicine, there is a risk that that medicine will reduce your sugar to a level that is less than what we would want your sugar to be. So, it is related to fasting before surgery, and we will talk about fasting a bit later. So, it depends on what you have been told about your meals. If your doctor has told you your surgery is going to be at 8 in the morning, do not eat anything or drink anything for 6 hours before that, then omit your morning dose of medicine. If your surgery is in the evening, if you are going to have your breakfast and have lunch and then start fasting, you can have your morning and noon doses of your medicine, and you can have your morning dose and omit your noon dose. So, it depends on the duration of fasting and whether you are actually going to fast. Certain medications like insulin should definitely be omitted, because they will bring down your level of your blood sugar very rapidly, and anyway when you come in for your surgery, your blood sugar level will be checked. So, if it is very low, we will pick it up. If it is very high, we will pick it up. So, do not worry too much about that single dose. What is important as a patient with diabetes, if you are going to undergo surgery and even otherwise, is that you have good long term sugar control, which will reduce a lot of long term complications.
And which brings me to the questions about fasting. Now, a patient might be wondering, okay, I am going in for surgery, why do I need to fast? What is the benefit, and how long should I fast, and should I be fasting for solids and liquids both, and if so, what is the duration? So, if you can just give us an elaboration on that, because that is one of the main points where our patients are confused, and sometimes they eat when they are not required to, sometimes they fast too long. So, I think our viewers would benefit greatly from your description on that.
So, fasting is done for both surgery under general and spinal anesthesia, and like I said, for local anesthesia there is no fasting. When you are under general anesthesia, your muscles are relaxed, and if you have food or liquid inside your stomach, the first part of your food tract, when these muscles are relaxed, they can come up, and the passage for food and the passage to your lungs share a common passage closer to your mouth. So, when the food or liquids from the stomach comes up, there is always a risk that they may enter your lungs, and that can have potentially lethal consequences. This is the main reason why we advise people on fasting, and some people actually think it is to harass, but it is not. It is actually for your benefit. The duration of fasting for a healthy adult depends on the amount of time it takes for food to empty or go out of the stomach. So, that is why we say solids like bread, biscuits, you fast for 6 hours. Liquids like milk, which are not clear, basically you fill it in a cup and you cannot see across that glass, you should fast. Things like milk, you still need to fast for 6 hours. Anything that is not clear, again 4 to 6 hours. Liquids, clear liquids like water, up to 2 hours. So, but last 2 hours, nothing to eat, nothing to drink. If you are having a heavy meal, especially things that are quite oily, it will take maybe even 8 hours to pass down. So, those are the general recommendations for fasting, but obviously if you have long standing diabetes, for example, the way your stomach works would be slower compared to a normal person. So, that will take longer to empty. Now, on the other hand, why can't we keep you fasting for 10 hours, 12 hours? Your body goes into a state of breakdown of the energy stores you have when you are fasting. We want to minimize that. The only reason we are asking you to fast is because there is a risk or a potential risk of this coming and entering your lungs. We do not want to overdo it, because we do not want you to be in a state of breakdown of your energy reserves when you go in for surgery. That is not good. You need your energy stores for you to build up and recover after surgery, and that is why we emphasize that you need to be fasting for the exact number of hours we have told you, no more, no less.
And that is a very elaborate and descriptive description on why you need to be fasting, what the duration, and I am sure you viewers would have understood the principle behind it, and I am sure you would benefit if you were to ever go in for surgery, which I hope you do not have to. And now moving on with our discussion, sir, now we spoke about fasting and preparation, and most of the time surgeons advise on patients to admit at a particular time, but we see it does not really happen, and sometimes they come in at the last minute, which makes life difficult for all the healthcare staff involved. So, I think it would be beneficial if you can advise our viewers why it is required that they come in a certain number of hours before the procedure, so that we can optimize the outcome.
Yes. So, when I discuss my surgical plan with a patient, it always ends up with the time that you are supposed to get admitted to the hospital, and that is going to be certainly a few hours before your scheduled time of surgery. That is because there are many things that need to happen from the point of admission to the point that you are taken inside the theatre. Some of these are administrative, but some of these are clinical or patient care oriented. We first need to ensure everything we have spoken about today have been followed. For example, have you fasted? Are you fasting? Have you fasted for the appropriate duration? Have you stopped all the medicine that you have been told to stop? Have you taken, sometimes we tell you to take certain additional medicine before your surgery, have you taken those? Have you got your tests that we wanted you to take? If you have not taken, we might have to repeat them when you get admitted. And then we need to do certain preparations. For example, we need to mark your site of surgery and the site of surgery. All of these things take time, and in the current situation, sometimes you may need a rapid antigen for COVID or even a PCR. So, if all of these things are not in order, we cannot take you to theatre, and we generally have a rough estimate of how long it will take, and that is the time we tell you to get admitted. The other problem is when you are coming in late, you are also anxious. Your blood pressure is high, your pulse rate is high. So, you are going to surgery as an anxious person, and the moment we take you to theatre and we connect you to a monitor, we notice that you are anxious, and then we are wondering whether you have not taken your medicine, and one thing leads to another. So, it is not as straightforward as saying my surgery is at 5 in the evening and I can come there by 4:30 and go straight up. It does not work that way. So, it is always better to follow your instructions, because a lot needs to be done, though it is a planned surgery and though we have booked everything, a lot needs to be done from the point of coming to hospital to undergoing surgery. So, always come at the time that you have been told.
Of course, we can always control and optimize the outcomes. The clinical outcomes would be better if we go through all the procedure that Dr. Dakshitha just described. So, it is not to harass you or to make life difficult for you that we ask you to come some number of hours before the procedure. This is to make sure that everything is in order before we send you to the theatre, because if everything is not in order, we might have circumstances where we might not be able to do your procedure as well. So, now a patient has come in for surgery, they have admitted, and we have gone through the basic clerking of the patient, and a surgery is an invasive procedure which needs consent, and these days most of our patients are very knowledgeable. They read up on their procedures and what the possible outcomes are. So, in this day and age and in this context, can you elaborate on what this consent is and how important it is from the patient's point of view, as well as the legal side of it as well?
Okay. So, consent is basically your willingness to undergo surgery, and what we practice now is called informed consent, and it is in the form of a written consent. So, it is informed written consent before any major surgery. Informed because you are making an informed decision, written because it is a written consent form, and there are many things that I discuss, and often just before the surgery is not the time to do it. You are anxious, you are waiting to undergo surgery. So, I often try to discuss and come to the consenting process during an outpatient encounter, because that has the freedom of and gives time to discuss. So, the first thing that I would discuss is what is the surgery and why we have decided. It is a collective decision between me and the patient why they are undergoing this surgery. Is there no alternative? Is there nothing, if there is something that is less invasive or less or a minor procedure than what we are proposing, and what type of anesthesia is required, and a big component of consenting is complications. Generally we talk about any complication that occurs more often than 1 in 1000, or if a complication is rare but has serious or lethal consequences, they will always be mentioned and documented. Though strictly not a part of the consenting process, I always talk about the postoperative recovery, what you can expect when you wake up after anesthesia, what you are expected to do and not to do in the subsequent week or 2 weeks, and of course any long term plans like whether you need a second surgery or a second intervention later. These are all things that we discuss in the process of consenting.
Of course, and with your explanation, sir, and with our time constraints that we have, brings me to the last question. Now, after a major surgery, after undergoing either general or spinal anesthesia, what can a patient expect in their recovery, and what are the do's and don'ts after surgery?
Okay. So, general anesthesia is when, like I said, you are unconscious or you are asleep. So, it is going to be like waking up from a sleep, though not as rapid. It is going to be a gradual recovery. You are going to be fully recovered before you are sent from the operating theatre back to your room, but it is in the operating theatre, in the area called the recovery area, you are going to gradually recover and gain your consciousness. We would have taken steps to minimize your pain of surgery at that point, but you may feel some discomfort, you may have some you may be nauseated, you may experience some vomiting. Those are side effects of medicine which we are aware of, so we try to minimize, and it is recovery from general anesthesia would be like that. Following a spinal anesthesia, both you will be paralyzed below your waist and you won't feel anything below your waist. So, you would gradually get that sensation and the ability to move, they will return gradually. Sometimes you might get your sensation quicker and you still won't be able to walk. So, it is very important that you do not try to get out of your bed before the doctor or the nurse advises you, because your legs may not be strong enough to hold you up. So, there is always a risk of falling. Another side effect or consequence of spinal anesthesia is sometimes the nerves that go to your bladder may also be slow to recover. So, you may not get the urge to pass urine. As a result, we will not discharge anybody from the hospital unless they have passed urine, but even after going home, there is a possibility that your bladder may not be able to empty. So, always your doctor will advise you to keep an eye out for that. In terms of post surgery, what to do, what not to do depend largely on the type of surgery you have undergone. Something small, there is no real precaution or things not to do. Whereas, say you have had major surgery, especially surgery of your bowel, there will be certain precautions, you will be advised what to eat, what not to eat, when you can go on to a normal diet. So, these are specifics that would be discussed with you after your surgery.
Of course, that was a very lengthy and descriptive description on what you can expect after surgery, after what you can expect after general anesthesia and spinal anesthesia, and it was a very informative discussion. I am sure our viewers got a very good understanding on how they should prepare, what they can expect. Of course, depending on your surgery, certain things may change, the specifics of it may change, but overall a general in-depth picture was given by Dr. Dakshitha Wickramasinghe, and we thank you very much. Thank you very much, sir, for coming in and educating our public. I am sure that the objective of the program is to try and optimize outcomes, try and get our viewers more educated. So, thank you once again.
Thank you very much.
And with that, it is time to take your leave from this episode of Healthline. Until I meet you again next week with your weekly dose of wellness, this is me, Dr. Dilshan Fernando, wishing all our viewers Ayubowan.